One of the things that we have continued to progress on at St. Francis is, I think, the true value in efficiency for all laboratories is not only automating all of your hardware solutions, like putting in a track system, but it's also automating as much of your informatics or your software solutions as you can. And one of the reasons that we do this and we continue to develop all of these new models in our laboratory is, frankly, survival for going into the next few years in healthcare. You know, we're taking huge budget cuts in Oklahoma, and I don't know if how many of laboratorians actually hear how much revenue we're going to be cut or how much our reimbursements are going to be cut in our laboratory, but that is a constant issue that is brought up to us by our hospital administration, and so we're having to justify now in our laboratory almost every single dime that we spend. We're having to really justify spending that money now. We're also currently 9 FTEs short in our core lab, well, actually throughout our health system. And administration has come through now and only authorizes to replace 5 of those openings. So we have to figure out now how to move forward into this next fiscal year 4 FTEs short. You know, and we're not allowed to have a lot of overtime either. So I think that's one of the reasons that we become so innovative in our laboratory is to figure out, okay, if I'm going to cut FTEs here, how can I do that? And I think the best way is combining both automation and informatics together and trying to really develop very lean processes in our laboratory. So let me continue. This is a picture of our new front. Actually, it's our new ER tower that we recently added. We now have a 2-story emergency room that's part of our new complex. So what I want to share with you today is different paths that we've followed in our laboratory and how we continue to improve. Because we're a very lean laboratory and we have a lot of people who come to visit our laboratory to look at our processes. And so we share these ideas with how we got from where we started really working and remodeling and renovating our lab 11 years ago to where we are today and the process path that we use. And then people ask us, well, you know, if you're 9 FTE short, how do you keep getting these new projects done? Well, we have a model that we followed for several years now on having weekly management meetings and assigning tasks, and I want to share that with you. And then the last point really that I like to hone in on is, you know, not only can you automate all your hardware and put a track system in, but you can also automate as much of your computer systems and not just your LIS, but your QC and moving averages, and you can tie all of these together and really help automate the informatics in your laboratory. And it's all about risk mitigation and error reduction in our laboratory. So this is a picture of our health system. We're a network that's located in northeastern Oklahoma, and we have the main hospital campus is now 1,150 beds. But like several of your facilities here in Dallas, we encompass everything. We have a large cancer center. We actually are the 10th largest pediatric children's hospital in the U.S. We perform the most amount of non-invasive cardiology procedures of any institution in the state of Oklahoma. So we've got everything. We've got cardiac, we have pediatrics, we have geriatrics. So we're a full service laboratory. But as our health system keeps expanding, we now have 9 laboratories throughout our health system that are all performing some level of testing. And what I want to show you, especially with the Bio-Rad product, is how I can implement and make changes for all 9 labs across the health system by sitting at my desk using the Bio-Rad Unity QC package. But that's just one element. We also use our middleware system to a very full extent. You know, probably a lot of you in this room are using some sort of middleware to connect your instruments now. You know, we in our health system switched to Epic last year, and we also had no choice. We were told we were going to use Beaker as the lab module. So if you're using Beaker now, you are required to use DI instrument interfaces, and there's a lot of pluses to doing that. So I want to show you how we basically use our middleware as our LIS in our institution. So this is a current snapshot of our core laboratory. Everything in our health system that we can with our testing is shipped into the core lab. So we have 18 draw sites throughout the health system. We have 9 laboratories that do some amount of testing, but anything that we can transport to the main core lab, we're going to do that because we can do it better, faster, and cheaper in the main core lab. So currently we're at about 6.8 million chemistry tests a year and 1 million immunoassay in the main core lab. But what I really want to focus on is in the middle part of that where we talk about our outpatients, because we draw about 1,700 outpatients a day throughout our health system, and outpatient work is pretty easy for most of us to run because that's fairly normal lab results. So a big push in our health system has been to automate as much of that process as we can and to auto-verify close to 100% of all of that outpatient work. But with that, there's some risks that you take because we're going to send 35,000 results straight across into my chart, because now all of these results go straight into Epic. And all of those outpatients can see all of those results on their iPhone pretty quick. So what we have done in our health system is we have a whole series of checks and balances that are built into the informatics, into the middleware system. So if our goal was, if we start to have any trouble with a chemistry analyzer, I want to be able to detect that within 10 minutes. And we're pretty much at that level now in our laboratory that anything that starts to happen on any chemistry analyzer, hematology analyzer, immunoassay analyzer, within 10 minutes we're going to be able to pick that up before we run into a big problem and have to call and correct any results in our laboratory. So I alluded to this earlier that a lot of site visits come through our lab, and they see the whole process that we've developed now, and they want to go back to their labs and they want to carbon copy or do what we've implemented in our laboratory. And so what we're trying to do now is almost develop like a blueprint so we can help share with new people that are starting this venture of automation and using informatics and using all these processes, how you can get this done. Because Dallas is the perfect point to talk about this, because we're all busy and we're all short-staffed, and then all of a sudden something hits you out of the blue like Ebola last fall, and none of us had time to deal with that, but all of a sudden within a month, all of us had Ebola labs set up. Not only did that hit you here in Dallas, but we still have our level 1 Ebola lab set up in our hospital. And not only did we go through Ebola and get all of that set up, then the measles hit us. So we actually, just a month ago, had an active new measles case that had just presented in Tulsa. So, the point is it's always something new that's going to hit us. And now we're having to deal with IQCP and get all of those procedures written and have that in effect by the end of the year. And I'm about to start our CAP inspection cycle. In fact, there's probably one of you that's going to come up and inspect me sometime this fall. So, there's always something that's hitting us, and we have to try to figure out how we run our labs, how we save money, and also, how we figure out how to get everything done and still run a quality lab. So, you've got the laboratory that wants to do all these projects, and then you've got IT that has a whole separate agenda. You ask IT to implement something, and they, most of the time will tell you, well, in 18 months, we might be able to put this on our docket. And then in the middle of all of this, you've got the physicians that come up through, or something like Ebola that hits us all of a sudden. So, these three processes all have to figure out how to interconnect with one another. And one of the things that we discovered in our laboratory and why we like to use middleware so much is the fact that med techs in the lab can make changes in this in DI and not have to wait for the IT department to tell us, well, you know, in 18 months I might be able to write that new rule for you. So that's one of the areas why we like to do as much as we can in our middleware. And you know, we still have to get these new projects done. So several years ago, when our automation line was being introduced into our laboratory, Abbott came in and you know, had great project management with us and taught us how to start this process, that you know, we've got to get all these tasks done. So we started having weekly meetings, and we just started forming a spreadsheet and giving accountability to, you know, well, the chemistry department, if you want to have this project done, then you're going to have to take ownership for it. And blood bank, if you want to have this done, then we've got to work on this, and these people in blood bank have to be responsible for this. This model has served us well through the years in our health system, and again, right now, we're very actively in this model because we just went live with Beaker. Anybody else in this audience on Beaker right now? Are you having a lot of fun with that? So the way that we're fighting these challenges is that we still continue to have weekly meetings and figure out, you know, what the hot topics are and what we have to work on first. And I can share with you that I'm the customer that calls up, you know, when my Beaker team can't get something done for me, we're calling up the Epic people directly and raising a lot of ruckus with them to try to get them to hurry up and help all of us, because Beaker is still in its infancy. But this project model has worked well for us to try to get through all the big hurdles in our laboratory. So what's developed in our laboratory is health systems come through, they see what we're doing in our laboratory, and then they leave and they say, okay, we want to do everything that they're doing, but they're so advanced, they're so far advanced than we are. How do we get started with this? So what we have done is actually helped try to develop a blueprint, and this is how we've ranked things. If you're going to start a series like this, you know, I'm going to rank these, I call these the top 10 of what every lab should be doing. And I think simply, number one, the biggest labor savings for any laboratory is strictly auto-verification. And you know, I'm shocked. I just think everybody is working at our level now, and when I get to go talk to a new lab or somebody comes to visit us and they're not using auto-verification in 2015, it just shocks me. But the latest, here's a great example of this. The latest laboratory that came through and looked at our lab and then they've moved off and are now trying to just carbon copy us is the Mount Sinai Health System in New York. They came through, they're putting a track system in very similar to ours, and they want to copy all of the informatics that we're using. And in 2015, Mount Sinai was hardly using any level of auto-verification, and that's a big prestigious lab on the East Coast. So there's still, in the Midwest, we actually are very progressive. There are still big, even university hospitals on both coasts that aren't using high levels of auto-verification, and that is the number one labor savings that you can do in any lab. Number two, I think everybody should approach next is using customized rules written into your middleware. It's cheaper to do it in your middleware than it is to have somebody write it into your LIS. A great example of that is we use the quadratic equation to calculate free and total testosterone. When we first wanted to implement that, because at that point that was our number one volume send out that we wanted to try to bring in-house, we approached, at that time we were using Quadramed as our LIS, and then we have DI as our middleware. Quadramed wanted to charge us $40,000 to have that equation put into the LIS. You know, with DI, That was basically one of the services that was part of our informatics package. So, you know, it was easier for us to implement that quadratic equation into our middleware. So that's, I think, a great example of how you can put complex equations into your middleware versus your LIS. Third, and I'm going to show you, I think the next best thing that every lab can do is run moving averages. Moving averages is like using QC in your lab 24/7 because, you know, we only run QC maybe every 8 hours. We run QC every 8 hours in our lab still for chemistry. On IA, we only do it once every 24, but moving averages runs all day long, and I'm going to show you an example of that in a second. Number 4, I think, is the Bio-Rad Unity real-time interface. It has a bidirectional interface into DI, and there are so many advantages for using that because if like I'm here today and they were having a calcium issue on one of our architects this morning, until they get that resolved, you know, that bidirectional interface is going to just shut off calcium testing on that analyzer. So that's part of our risk mitigation package that, you know, even if somebody is not paying attention or they don't review their QC before they start running patients, you know, even if all of that is neglected and they get a phone call, you know how we all get distracted, you know, then calcium testing is just going to be shut off on that analyzer. And then the last thing of the top 5 I think every lab should be doing is using the CAP interface now, the eLab Connect. It was interesting, last fall, DI had a user group meeting here in Dallas, and there was a CAP lady at that meeting, and you know, I've suspected this in my gut all along, but you know, 99% of all the errors we make are clerical. They're not analytical. It's the problem we have trying to transcribe those results onto those worksheets. And, you know, for all of you out there who fill out the general chemistry survey, you know, I used to go lock myself into my office and I'd still get phone calls. And that was, you know, when we used to report 2 instruments, that was 80 pages of data. And now, since we've got the CAP interface going, you know, we just run our CAP surveys on our architects and all of that just auto-populates onto the CAP website. It's wonderful. So those are the top 5 basic things that I think everyone should be doing. And then there's what I call the next category of where you can really start to get very efficient after that. And for the Abbott users out here, you can have calibration factors that your service guy can help you set up for all of your calibrations on all of your instruments. And I love this because it will automatically fail any bad calibration. And generally, it's when, you know, somebody just switches calibrators or they grab the wrong bottle, or usually it's a careless mistake. But cal factors and the use of that won't even let that calibration come to complete. So it helps save us, again, with the risk mitigation process of stopping bad cals. And then Abbott has a remote diagnostic feature called Abbott Link, and it's the way they connect all of their architects. But there's a lot of efficiencies that you can gain through that, and we have reports that get emailed to us every day. In the middleware, there is a way that you can run reports out of the middleware instead of trying to extract data out of your LIS. And I would like to have a conversation with you after this to see if you're getting any crystal reports to work out of Beaker. Okay. Point well made. So we're looking for other sources now to try to get report data because, you know, frankly, it doesn't work very well out of Epic. So you can set up ODBC reports or a way to run reports out of our middleware, which we do. And then the last thing for the DI users in here, you can network EP Evaluator. So we now, on all 9 testing sites we have EP Evaluator connected through the network. So at any one of our testing sites, if where they're doing a linearity or a method validation, you know, we can suck that data in automatically off of the instruments, and even I can do all of their linearities for them. So that's just a really nice feature, and I want to show you how I do multiple instrument-to-instrument correlations. We even do it weekly. And I don't want all of you to gasp and say, oh my God, that's so much work, because I want to show you, you know, we actually get, it's a way that we can stay on top of our instruments and see how all of our assays are performing. And I actually love this feature. And then the last thing that we're doing in our laboratory now is we've automated inventory. We have it on an RFID cycle. But you know, what's the outcomes been of this? Well, you know, it is so much easier to work in our lab now than when it used to be even a few years ago. And this is a big plus for us because probably like a lot of your labs, a lot of my techs are my age and older and they're retiring. And I don't have a workforce to replace them. The nice thing is I actually have older techs now that tell me, I don't want to retire anymore because, you know, they like coming to work. Last year, we poll everybody in our health system, and there's a Bio-Rad lady sitting at the back table back here that used to work in our lab. And last year, we poll all the inpatients and outpatients and all the physicians in our health system. And last year in the Core Lab, we got the highest polling rating of anybody, of any of the nursing units or anywhere else in the hospital. So in fact, we actually drive some of the older immunology ladies, we drive them crazy because out in the Core Lab, we laugh and giggle all day long. So I mean, the techs working in the lab actually enjoy coming to work now. But I think the bigger part of this is we have, and I don't know if Liz ever paid that much attention to this, on our hallway when we walk in, we have 5-star physician awards that post our hallway. And 4 out of the last 5 years, the physicians in our network, and that's all the outpatient physicians and the inpatients, they get polled on 3 questions every single year: accuracy of results, availability of results, and the test menu that's available to them. And 90% of the physicians in our system rank excellent on all 3 of those questions every single year. And I don't know about you guys, but I don't give anybody an excellent because I'm pretty tough. So but I think that shows that we've developed this informatics process in our laboratory now to the point where we don't have to ever call and correct results anymore because we're able to catch an error or anything that starts to happen on those instruments basically within 10 minutes of when we have an error start. So I mentioned that I think probably if you're, after auto verification, the next thing that everybody should implement is moving averages, using that in their laboratory, because it's just like running QC 24/7. All day long while you're running, your assays are making points on that graph. And I think when DI originally developed this and put it into the software about 3 years ago, I don't think they ever thought a crazy customer like we would stick them up on a big screen monitor in our lab, but we actually find a lot of value in watching these graphs because we can point anything that starts to go up or down and start tracking it very closely because, and you don't even have to be a math major to do this. All the techs in the lab have to do is follow that. If a graph starts to go up, it should immediately start to come back down. If it goes up and stays up, then they need to go pay attention to it. And in the software, you can program this to automatically just shut your analyzer off so it stops testing. So a real life example of this is, I think on the top left graph, I'm showing a graph of creatinine. So all day long while we're running, and this is inpatients and outpatients in here. Everybody's in this population. We have 3 chemistry analyzers, so you can see 3 lines there, a pink, a blue, and a green. So all day long, they pretty much stay right along the mean as you're running. What you can do is the yellow bar represents the 2 SD line and the red bar represents 3 SDs. So in our laboratory, we've adopted a practice of when something hits a yellow line, then we hit the 2SD mark, we just simply shut off the assay. So generally, that's something like total bilirubin, and it just simply needs to be recalibrated. When something goes down and hits the red line at 3SD, you've got an analyzer problem. So at that point, if something hits the 3SD mark, we just shut the analyzer off. And a perfect example of this is on the bottom left graph. That's an example of calcium. That's a true life example in our laboratory at 10 o'clock on a Friday night. You know, at 10 o'clock on a Friday night, all the kids in that lab that are under the age of 25 are at the time clock and they're ready to go see their movie that they're all gonna go see at the end of the night. You know, we're ending our busy outreach testing for the week. Everybody's tired, they wanna go home. So nobody was around those analyzers. And we actually had a waste pump that plugged up on an analyzer. But the cool thing was within 10 minutes, that blue line goes down, hits the 2SD, hit the 3SD right after that, and we were able to automatically stop testing on that analyzer. So, you know what, we did not have to call and correct any results out of that batch. And if you were just using QC to gauge your instrument performance, you know, we would have run QC at 3 o'clock in the afternoon. We wouldn't be running QC again till midnight. We don't bracket in our laboratory. We run everything real time. So, you know, we could have had the potential of having 200 calciums here that we would have needed to repeat. The cool thing about this is the software can just automatically stop testing for you. So, and another neat thing in this is in the software, you can actually have it programmed to which analyzer and which assay it is. And so on every chemistry PC, this little box pops up, and that happens on every chemistry PC in the lab. So no matter, you know, if somebody's not at a PC at that exact moment in time, they're going to see it as soon as they return to that PC. So I talked about, you know, that the #1 labor saver that everybody can be doing is strictly auto verification. Well, this is an example of our auto verification rates. We're usually at about 91% for heme and 85% for Clin Chem IA. This is strictly the biggest labor savings there is, because if you're going to look at a result and you're not going to do anything with it or change it, you don't need to be looking at it. A great example of how we turned hemoglobin A1C into a walk-away workstation about 2 years ago was simply, we run HPLC for our hemoglobin A1C testing. It's not on a track yet. We're going to put it on our next phase. But we have 2 analyzers that are just sitting on a workbench over in the corner of the lab. You know, we get boluses of hemoglobin A1C tubes. So I used to have to have a tech that would stand at that analyzer, and that was 1 FTE devoted to that workbench. Now, we don't have anybody back there. We simply take 200 tubes at a time, go load them on the analyzers, and walk away, because we wrote rules into our middleware system that, you know, 99% of all of our hemoglobin A1Cs auto-verify now. And anything that we need to be looking at, which is a hemoglobinopathy, will automatically be held up. So when a tech returns to that workbench 4 or 5 hours later, you know, they may have 10 chromatograms that they really need to stop at and look at it and review. This is a perfect example of, you know, you don't need to have a tech that's sitting at an analyzer looking at chromatogram after chromatogram. You can write a rule and just target the ones that you need to look at and let the rest of them flow on through the interface. So here's, you know, I think the Bio-Rad people brought me down here today. We're a big user of Bio-Rad Unity Real-Time. And the reason that I love this product is the fact that it's got a bidirectional interface into Instrument Manager. And it also fits all of our QC regulatory requirements. So we manage all of our QC in Bio-Rad Unity Real-Time. So all of our techs, and it's not just our architects that are integrated into this. We've put all of our QC in the core lab, and now across the other 9 sites where we're doing testing, all of that QC goes into Bio-Rad Unity real-time. So it collects all of our data. It automatically sends the data off to Bio-Rad at the end of the month. We get our reports back to us. We do everything electronically, so now this entire process is paperless. And the best part of why I really like to use this product is the fact that it's got the bidirectional interface. So if somebody runs QC and that QC is out, it's going to stop auto verification, or you can completely shut off the assay until your techs take corrective action. So that's the nice part of it. Even if they're in a hurry, they fail to see that a QC point was out, they haven't documented their corrective action yet, there's no patient results that are going to go anywhere until they've corrected their QC. So that's the major reason of why I like to use this software, is the fact that it's automatically going to hold testing for you until they get the QC matter resolved, whether it's having to recalibrate the assay, whether they've gone into a new lot number of reagent, whatever the reason is, it's going to stop patient testing until they've resolved what the QC issue is. Another point of this that I really like is the peer review functionality of this. How many, just for my information, how many of you out there are using this product right now? Not as many as I thought. Okay. Did your vendor, because the Abbott people showed this to me, did you know in the peer review group that you see your lab on the right and the peer review groups on the left? So that's one of the things that with all the big architect users, we kind of have an informal user group around the country with all the big architect labs. And when I start having trouble with PTH or vitamin D or folate, there are a handful of the other big users that we're going to start communicating with, and Maggie is one of my people that I communicate frequently that was here in this audience. So it's a way that we can detect assay troubleshooting measures. So, if folate starts to take a dip on me in my QC, I never know whether it's me or whether the hard part for all of us is to understand whether it's our analyzer or whether it's the QC material or whether it's the reagent lot that you're on. So, that's why I like to look at the peer review group, because, I can see if the entire peer review group is shifting or if it's just my own analyzer. And so that's, the first thing that I've taught all of the techs in our lab when they start to have trouble with something and they've had trouble for more than one day. All of the techs in the lab, we've educated all of them. Go look at your Levy-Jennings chart and look and see how your lab or how we're doing compared to how the rest of the other peer group is doing. I love this feature on this. And then we have gone completely paperless in our lab with QC. It's just another way to get rid of all those binders and binders and binders and notebooks of all that paper that we had. And with the Unity real-time package, we have this set up on all the PCs that we have where we release our Epic Beaker results. Everything's loaded on the same PC. So the techs have just now gotten into the habit of, as soon as they run QC, they go to their PC, they pull up Unity, they document acceptance or their corrective action of their QC, and that's just part of their workflow. So in this software, we're able to document our corrective action. There's supervisor review. So everything for our CAP regulatory compliance, we can do electronically in this package. Another thing of why I want to automate everything in our laboratory, we're 9 FTEs short, and I already work too many hours in the day. So one thing that's really easy for me to do now, especially with, we've got architects now in 4 of the 9 labs where we're doing testing. And I keep us all on the same QC lot, so all the labs are on the same chemistry lot, the same immunoassay lots, and so when I bring in a new lot of QC, I can go into Bio-Rad and I can copy that across all the reporting labs and install that for everybody all at once. I think that's huge. I don't have to physically go to those labs. When we get a new lot of cardiac marker control, I can pull it up, I can have it installed in a matter of seconds, and then the template is there for all the other labs to use. I love that feature. And another part is that myself and my manager daily, we look at the QC across the system with all of the architects to see how everybody's doing. And it's a way that we can catch if a smaller hospital is starting to have trouble with troponin. We can immediately see that they're taking a dip in their QC and help do problem resolution. And it's very convenient that we can see all the labs in the health system in one package. And again, this is what I was alluding to. We have 9 different labs now that are all in this product. And it's easy to do this and have it all in one package, and then my manager sits down every single morning and looks at the QC across the entire health system. So it's really nice to have all of those in one user interface and one package that we can look at. Okay, then here is probably my biggest love of this feature. Even when I'm here today, traveling to Dallas, I'm telling you, we had calcium problems on one of our architects this morning. While I was flying, I was trying to help them do some problem resolution on that, but the nicest thing about that is in the toolbar, and I don't know how many of you are using this connected into DI, but in the toolbar, there is a little red stop sign that shows up, and any QC violations that have happened, the techs have to go in there and take out that red stop sign and have documented corrective action before we can start releasing patient results. So even in these busy days, if somebody's taking a phone call, somebody forgot to go review their QC, they've got this instrument back online, they're running patients again, and they've not resolved that problem, patient testing is going to be stopped until that QC value has been corrected. And then another feature that we like about this is we are totally paperless in our laboratory now. So, the techs are handling all of their QC in the software, they're doing their corrective action, and then on the flip side of that, when we get all of our QC reports back every month from Bio-Rad, we're electronically signing those and then electronically filing them. So it's just, this is a nice feature that we've had in our laboratory so we can become paperless. Okay, the next area that we've started monitoring all of our assay performance is not just with QC, because as I stated before, QC is only detecting how your analyzer is running for that moment in time that you're running QC, and the other 7 hours and 59 minutes until you run QC again, you really don't know how your analyzer is performing. So I think there are other steps that we should take to have continual monitoring of your analyzers. One of those, and the big proponent I talked about, was moving averages. Another feature that we use, and we follow this monthly, is following our sigma-metric performance of all of our assays. There are several ways you can do this. Bio-Rad Unity Real-Time actually calculates it for you in their data analysis grid. EP Evaluator also calculates this. So across all of our labs, on all of our architects now, in EP Evaluator, you can automatically have that data calculated and we capture it. We look at this monthly. So we do this as another example of how to follow our assay performance. So we benchmarked all of this years ago, and then we follow it. And if I'm running along with a 6 sigma on T-bill, and all of a sudden I drop to a 4.2 the next month, I want to know why we did that. What happened? Did we change the reagent lot? Did we change the calibrator lot? Am I calling up the manufacturer and asking what happened to the performance on that assay? We've been able to detect significant shifts in calibrator lots by following processes like this. So one of the reasons we do this is to gauge both assay and architect or analyzer performance issues. And so we capture this data monthly out of EP Evaluator, and this is another thing that we monitor. And then in the top 5 I talked about earlier, I think one of the biggest errors or ways to reduce errors is using the CAP interface. When we run all of our CAP surveys now, all of that data now just automatically flows onto the CAP website. So you have to get this interface or pay to have this connection established. But once you do that, then when you go to run all your CAP surveys, we chose to use the kit number as the first name of the patient, and then the actual vial number, like on the general chemistry survey, you would type in exactly what's on the bottle. CHM-01. So that's our last name, and then as we run those samples on the analyzer, all those results automatically cross through the DI interface and populate onto the CAP website. You know, that's taken the clerical error part of it out of the equation, because that data, there's no more clerical errors because that data is automatically going straight to the CAP website. Now, it doesn't, you know, at first I was freaked out and thought, I'm never going to use this because something's going to go across and I'm not going to know about it. It doesn't, that's not exactly how it works. The data pre-populates onto those pages, and then you still have to go through and approve them, just as you do now when you're submitting things on the CAP website. You type all the data in, then you have to go through the second time and approve it, and so that you still have the approval process. And then I told you that weekly now in our laboratory, we use EP Evaluator, and we do instrument correlations across our health system weekly. You can network EP Evaluator across your instruments, across your health system. So we started doing this a few years ago, and CAP tells us we have to do it every 6 months. We started doing it in this format because it was an easy way for us to do instrument-to-instrument correlations. And by doing it weekly, we're doing another thing of trying to gauge analyzer and assay performance across the health system. Because, you know, there's probably two assays that we want to have the same value on across every single instrument in the network. One of those is creatinine, and the other one is hemoglobin. Reason we follow hemoglobin, and all the blood bankers in this room should really appreciate this. We have 3 sapphires sitting in our core lab. If you take a tube and you're going to run it across all 3 sapphires, and you're going to get a 6.9 on this one, and a 7.0 and a 7.0, guess what? We're going to be transfusing based off of this 6.9. We're not going to be transfusing on the 7.0 value. That's one reason why we follow moving averages and also do these instrument correlations, because it's more than just running QC values. You want to be having the same value across all the instruments in your network. Same thing with creatinine. You know, we want to have the same creatinine value on a patient, whether it's on an iStat or it's on an architect, across the entire health system. So this is one of the reasons why we do these correlations. And when I'm talking, I always tell everybody the good, bad, and the ugly of what we're doing. And so I like this graph that's in the center. And I'm showing, I think, ALT on this one. And the top 3 points are our 3 architects in our core lab. And then the bottom 2 are architects that are at a smaller hospital in our system. And guess what? ALT doesn't look too hot on those architects at the smaller hospital. So, you know, this is an example where you called them up and said, I think we need to be calibrating ALT. But what we want to see, and this is what I want to see with creatinine every single week, you want to have all 5 of those points nice and tight right on the center line. So that's what we strive to see. So if, this is an example of how we follow creatinine, because we're a big dialysis place, and if you send out, this is what's scary these days. Doctors rely so much on our lab results and they take them verbatim. One bad creatinine can send somebody to dialysis. So that's one reason why we're such sticklers and follow this data so closely. So in our health system, since we've made a lot of improvements through the years, and I'm a big proponent of keeping everything in one computer system, whether it be Cerner or Soft or whatever you're using. When we put everything into our DI interface, we just continue to improve our turnaround times in our laboratory. So the first part of this graph is when we brought in our automation line and we had ClinChem and IA in Instrument Manager or DI. In the middle of that graph where it says HEH implementation, that stands for high efficiency hematology. So that is the point in time then where we brought in hematology, coag, UA, immunology, the rest of the core lab. And then what we've been able to do in subsequent years is pretty much peg out our turnaround times for our emergency rooms. So now consistently month after month, we stay at 97%. Right now we're going through the stroke accreditation process in our health system. So we're becoming stroke certified, and we're going to do that without point of care in the ED. Because in our institution, it's really important for us to have control over that testing. And we don't want to have, we've kept out this long without having troponins on the iStat in the ED. So we do everything we can with running the volume of testing that we have, because we're going to run 5,500 tubes a day through our track system. And all of our stats and all of our ED samples and pediatrics and everything runs on that track system together. So what we've done is continue to refine our workflow processes and stay on top of these times, so we've been able to facilitate that. So these are our average times for our ED specimens. So we're at 6 minutes for CBCs. We continually stay at 25 minutes for troponin, and then PTs are on a Stago at 15 minutes, and then BMP and CMP. These are emergency room times, and these are this is from receipt in the lab till result on the chart. Now the next part of this that we're measuring, since we're becoming stroke certified, is we're also now capturing that time from door to result. So that data we're capturing right now, because that, as you all know, that's another whole piece that we can't control very well, is that part that's happening in the ER when they first hit the door. So as why people come see our health system and are impressed with how we've tied all of this together. In our health system, we've gotten the Clinical Excellence Award for 3 years now in the emergency medicine. But what I'm most proud of in our health system is when I was talking about the physician ratings, for 4 out of 5 years now, the physicians give us excellent year after year in those 3 top questions. And I think it's not just because we put in a track system, and it's not just because we're using DI. I think it's really the key is how we've got using cow factors and moving averages, and we're able to catch errors in our health system very quickly when we're running this large volume testing. So I'm willing to answer a lot of questions. I thank you for all staying awake this afternoon, and thank you for your time.